This conference will now be recorded.
Okay, so welcome all of you to class. So people send so many requests for this nice infertility. So in today's class, I'll be covering nice infertility and also male infertility. Okay, so yeah, so coming to let's start. So this is all according to nice guideline infertility. So infertility affects 1 in 7 heterosexual couples in UK. Okay. So this number is important because we will get a question from this number. Then causes of infertility. Unexplained infertility 25%. Ovulatory is 25%. Tubal damage 20%. Male infertility is 30. Okay. This question has been asked many times, and unexplained infertility also it has been asked many times. And uterine or peritoneal disorders, these are 10%. So this number by heart you have to remember because you will find direct number question from here. Apart from this, for male or female, both side infertility, there are 40% of the cases. So like all this number, what are written in this table, in this slides are important, and from all numbers and percentages, you will find questions in the exam. Okay. Now, fertility do have psychological impact, and stress like to reduce libido and frequency of intercourse. Okay, that causes the contribution to fertility problems. So counseling before they think go for it, after it, and during treatment is recommended by NICE. Okay, and what they say that there has to have an independent counselor, like the person who is who is if any person, the doctor or the clinician who is involved in the treatment of the couple, he will not counsel. So there has to have an independent counselor. Okay, so this part is important for part 2 people to know, and part 3 people they have to put in the stations. Okay, now coming to chances of conception. So again, whatever the number I have colored here, from yellow, that all numbers are important because you will find questions from all numbers. So what are the chances of conception? Okay, so 80% of the couple, they will conceive within a year. What are the conditions for that? Woman has to be 40 years of age. They are not using any contraception. They are having regular intercourse. And what they called as a frequency of regular intercourse, that is also important because it can come in part 2 question, and part 3 stations you have to speak that to role player. Okay, so it is like it is every second or third day they have to have intercourse. Fine. Now if these criterias are there, then 80% will conceive in 1 year. You will get question from this number. But if they are not able to conceive in a year, so half of them, they will still get pregnant in 10 years. So total cumulative pregnancy rate over 2 years, it is 90%. So these two numbers are important, and you will be getting questions from these numbers. Apart from this, coming to IUI, if 50% of the women, if they are under 60%, 40 years of age, they will conceive within 6 cycles. Okay, you will get this question. So after 6 cycles of IUI, there are 50% chances as women will get pregnant. But if they are not getting pregnant and you offer them 6 more cycles, that is 12 cycles. So in the 12 cycles of IUI, cumulative pregnancy rate is 75%. These numbers you have to remember because both of these numbers, they are usually asked in the exam. Now that is a fresh sperm associated with higher conception rate than frozen sperm. That is quite understandable, and it is why I have put it here because because sometimes you will get in some stem of SPA. Apart from this, female fertility decreases with age, everybody knows. But yeah, age do have an impact. Male infertility is also decline with the age. Okay, So you have to know, because SBA can come from, suppose any stem can come from here. Now this is the frequency of intercourse that is recommended by NICE guideline. So vaginal intercourse every 2 to 3 days, okay, optimizes chances of getting pregnancy. This is very important because they don't believe, NICE guideline doesn't recommend anything like having intercourse at the time of ovulation. They're not saying that, because they say it's a stressful period, so they have to have intercourse every 2 to 3 days. That is the frequency they recommend. So for part 3 people, it is very important because they make mistake. So they have to speak this, okay. Artificial insemination, yes, it has to be timed around ovulation. Now coming to lifestyle modification, I have seen question from here also, so it is important for you guys. Lifestyle modification, if they are planning for natural conception, so these lifestyle modification again will be coming in the upcoming slides, but the lifestyle modification will be for the couple if they are going for IVF pregnancy. But right now, so you have to understand it, because the people make mistake here also. So lifestyle modification for natural conception, what is that? Alcohol for women. For female, it is 1 to 2 units, once or twice a week. Okay, this is like limit they have recommended. But acute intoxication should not happen. Like they should not do it excessive amounts. So that will be harmful for developing fetus. You already know what can happen is the fetal alcohol syndrome. For men, alcohol consumption is 3 to 4 units per day. Okay, excessive alcohol for both male and female, that will be detrimental to, for male it is detrimental to semen quality. So this is update about alcohol. Smoking, they don't want female will be should be informed that they will reduce infertility. And even the passive smoking, so if they're not smoking, but if they are doing passive smoking, then also that is affect their chances of conceiving. And so in the UK there is a stop smoking services. So all of the females, they are usually offered to the stop smoking services. Apart from this, you will find questions like how smoking affects female infertility. So actually smoking do have some effect on the tubal motility, okay. So this is a possible thing that I was able to find. Yeah, but it is not written in the NICE guideline, okay. And men smoking, it has an effect on the reduced sperm quality. So that I'll be again speaking when I'm discussing about talks. And the caffeinated beverages like caffeine has got no problem. So this is important sum up for the lifestyle modification, what they are looking for, natural conceptions. So alcohol, female can take 1 or 2 once or twice a week. Male can take 3 and 4 units. But excessive amount of alcohol is banned for both of them. Smoking, female and male both are affected. Not even active, it is affected. They are affected with the passive smoking also. Caffeinated beverages makes no sense here, okay. But it is caffeinated beverages do have role during IVF. If they are going for IVF, it will have a role. But in the lifestyle modification for natural conception, coffee has no role. Caffeinated beverages, no problem. Now, weight modifications, that part is important because many of your questions, they will be depending upon this weight modifications. So women who is more than 30, if they're not ovulating, they should be losing weight because that will increase chances of conception. Usually there is a group exercise and diet program. So all of the women ideally refer to that program. That line has to be useful for part 3 people because they have to refer to that woman there. For men also, BMI more than 30, they are likely to reduce fertility, okay. So if you find in your question the woman is obese and the BMI is more than 30, your answer will be only weight loss, okay. Apart from this, low weight, if the BMI is less than 19, then also they would have an irregular menstruation. They would not be ovulating. In that situation, they would be advised. They would be advised for increase in the body weight. Okay, so that this is all about weight modifications. Now coming to other modification, like they do have some specification about this, what they say that if the tight they're wearing, males are wearing tight garments, then there would be elevation in the scrotal temperature, and there will be reduced semen quality. But it is also it is also uncertain whether if they are advised to wear loose fitting garments, so will it improve fertility. So actually there is association about increased scrotal temperature and also in the semen, reduced semen quality, but there is no evidence is not there that losing garment, wearing loose fitting garment will help. Okay, apart from this, some of the occupation, they also have they expose them to hazardous things, male and female. So occupation inquiry, those who have come for the fertility thing should be done. Okay, now many of the people, they are many of the patients or role player in the exam, they are taking some over the counter drug or recreational drug. So you have to do the specific inquiry, because part 3 people will find the station. So sometimes they are taking that John Watt, sometimes they are taking herbal medication. So they are taking, they're by themselves taking medication, and they usually interfere with your treatment. So this considered to be sort of a safety part in part 3 fertility station, that you have to make a specific inquiry. Okay, and there are certain complementary therapies are there, but NICE recommends evidence-based practice. So evidence is not there, so complementary therapy are not offered. Okay, now coming to folic acid, that you already, every one of you know. So what they recommend, folic acid has to be started before conception, and it has to be taken 12 weeks before, till the first 12 weeks of pregnancy. That decreases the neural tube defects. Recommended dose, you will find 0.4 milligram per day or 400 micrograms. Now there are certain indications where higher dose of folic acid will be required, that is 5 milligram. So if like previous baby is with neural tube defect, if anti-epileptic medication that has got antifolate action is there, or if diabetes is there, or another, like if the high BMI, more than 35 BMI is there, then in that particular situation they has to offer 5 milligram of folic acid. And usually question also comes from this line in the exam. Now coming to fertility assessment, what NICE recommends. So like what is so if after 1 year of unprotected intercourse there is no pregnancy, that is the definition of infertility. Okay, so if there had been complete 1 year and there had been no after of unprotected vaginal intercourse and no pregnancy, then this couple should be referred for assessment and investigation. So this is for the people who are trying naturally. But second situation, if the patient is going with a artificial insemination, they are IUI is the method they are using for fertility, then and they have not conceived after 6 cycles, then they should be offered clinical assessment and investigation. Okay, so these are 2 things you have to remember. For other couple, it is after 1 year they would require referral. For the couple they are using artificial insemination, they should be referred after 6 cycles of IUI treatment. It appears to be confusing, because when the IUI is done with a donor thing, then their recommendation is different. That will be just coming in the upcoming upcoming slide. So it will be really important to remember that after 6 cycle of IUI, they recommend to go for clinical assessment. Now there are few things, few specialist, few early referral will be required in some conditions. What will be that condition? If you find that your patient is more than 36 years, you can't let her wait for one more year. So if the woman is more than 36 years or she's over, so early referral can be done. Okay, number one. Number two, if any previous clinical cause of infertility is already known, like if you already know that this woman is infertile, why we should ask her to wait for 1 year more? That will be unnecessary increasing her agony. So it is really important that you have to ask both things, because for part 2 people it will be real important, because you will find question and you have to see the age of the patient, and then according to that your answer will change. So this is a nice recommendation for fertility assessment. Now there is certain special consideration according to NICE. So if like a patient is going for any cancer treatment, okay, so in that particular situation they should be referred to the fertility specialist early. Why? Because some of the chemo like gonadotoxic chemotherapy may be used, radiotherapy may be used. In that particular situation, that person may become infertile. So before treatment is planned, referral to early referral to fertility specialist should be offered. So you will get a stem of question and your answer will be referred to fertility specialist only. Apart from this, there would be some patients, they are positive for hepatitis B, C, HIV. So what to be done if they are looking for fertility? So for them also they should be referred for appropriate center, so that appropriate expertise where the expertise are there, and usually they should be explained about the risk reduction thing. Okay, how the risk reduction during investigation and treatment can be done. So in this particular situation, if the scenario, if your questions bring something about that, so your answer will be only referral, because in part 2 many times a question of answer is only referral. Now investigations for the male infertility, we already know what investigation we do for male infertility. So first investigation that we do is a semen analysis. So WHO reference criteria are there. So these are the criteria, and all of you have to remember these criteria by heart. Why? Because you will get question, the criteria are given. From these criteria only you will be able to find whether there is a problem is there in the semen or not. Okay, so semen volume, it is 1.5 ml or more. pH should be 7.2 or more. Sperm concentration. Now there are two different things are there that you have to remember, understand, because people make mistake here. So sperm concentration, if it is sperm concentration, then the value is 15 million per ml. Okay, this is per ml. But if it is total sperm count or total sperm number, it would be 39 million per ejaculate. Okay, so there are two different numbers that you have to remember. Some, because people make mistake, they will read concentration and they will take this value. So this is the common mistake people do. So you have to understand, if it is sperm concentration, it is 15 millions per ml. If it is number, then it is 39 million per ejaculate. Okay, now coming to motility, so you will find two type of thing. Total motility. Okay, total motility will be percentage of progressive or non-progressive motility. That should be 40, but if only consideration for progressive motility, it is 32. Apart from this, vitality 58% or more, live or more. Okay, so if more than 58% live spermatozoa has to there. Apart from this, they do have some criteria for sperm morphology, and more than 4% and more. Okay, so this number you have to, these all the numbers you have to remember, then only you will be able to do your questions. Apart from this, what they recommend, there should be abstinence of 3 days. And when the semen is sent to the lab, before that time it has to be kept as the normal temperature. Okay. Now if you find some problem has come up in the semen test, so what you will do? So if it is abnormal, then repeat test has to be done. Now when you will do it? So you will do it 3 months time. And why this 3-month time? Because we already know cycle of spermatozoa formation takes 72 days. Okay, from our UG days we already know. So we want to give that time for sperms to get developed. So we do this test after 3 months of time. Okay. Apart from this, so this is one situation. Another situation, you will find a semen where there is azoospermia is there, or severe oligospermia or azoospermia is there. So in that situation, why to need not to wait for 3 months time? So repeat test should be done as early as possible. Okay, so these are the two things that you have to remember, because you will find question from there. Even the same thing you will find in part 3 also. So if it is like abnormal semen, like few parameters are abnormal, not an issue. Ask them to do test after 3 months time. But if you find okay, it is azoospermia or severe oligospermia, you have to ask them to do test as early as possible. Okay. And no test for anti-sperm antibody for according to NICE is recommended. So there will be no test for anti-sperm antibody. Why it is important to know? Because you will find many of the questions where they are asking this line. So you should know that that is not recommended at all. Now coming to this definition is also important to remember. Mild infertility if two parameters or if two or more semen variables having one or have one or more variable below 5th centile, then it is called as a mild male infertility. Okay, so one when two or more semen analysis, this includes the number of times semen testing has been done and one or more variable. So whatever the WHO these are the WHO thing, whatever we are getting here, these are 5th centile. So if one parameter is not belonging to this parameter, then in that particular situation we will give that definition of mild male infertility. Okay, understanding this is important. And why this is important? Because when you solve question, then usually they will show you mild male infertility, and and the treatment options for mild male infertility is different according to NICE. I'll just come to that. So then you have to give answer according to NICE. What are the investigation that can be done for female infertility? So if the cycle, so this is why we do question wrong, because whatever the practice we do in our countries or in our clinics is different, and what is the UK recommendation is a bit different. Okay, so according to them, if you have to find out about the ovulation, so regularly, if the patient says they are having regularly monthly cycles are there, so they're likely to be ovulating. So if you have it from the history, yeah, this woman is ovulating, then you will do only one test. That is a serum progesterone level, and that is done in the mid luteal phase of their cycle. That is day 21. Okay, day 2. If the cycles are 28 days cycle, regular cycle, so you will do at day 21. Okay, and so for ovulation they are doing only this test. So therefore, why it is important to understand, because in the questions you will find serum progesterone value, and looking at that you have to find out whether this ovulation is happening or not. Apart from this, now the woman has come to you and her cycles are not regular. So how you will find that she is ovulating or not? So serum progesterone will be done at they will do it later in the cycle. Like maybe they will do at 28 days of a cycle, then they will repeat every week until menstrual cycle starts. So this way they will able to know whether the ovulation is happening or not. Apart from this, you will find some questions. So she is coming with totally irregular cycles. There, all of a sudden a period will come and there is no pattern. Okay, so in that particular situation, you can't take a test. Um, uh, Depends on the day of cycle, because we already know usually we do take test at second or third day of the periods for this serum gonadotropins. But if a patient has come and her cycles are not clear, she's not able to give you track of cycle, she is having irregular cycle, then what you will do? So the day she has come to you, you take this the serum gonadotropins level. So this practice, like, it is different from what we are doing and what NICE recommends. Usually when we do investigate female for infertility, we do all tests. We do serum gonadotropins for every woman, okay? But no, according to the NICE, for your exam, part 2 and 3, you only for ovulation, only one test, to day 21 progesterone. For irregular cycles, they is the only situation where they are offering gonadotropins. So this you have to understand to make your questions right. Okay, so now many of the people, they don't know progesterone normal values, so therefore I have put it here. So if it is nanogram, then it will be 5 to 20, but in for the sake of this MRCOG, the value is usually given in nanomole per liter. This value is given in the exam. Okay, for your like 2 and 3 people, so you have to remember you have to know this value. And any serum progesterone the value that is more than 30 nanomole per liter, if they have given more than 30 value, this woman is already ovulating. So you have to check the serum progesterone values, then you will get to know, yes, the ovulation is there. Now, unnecessary tests are not done in recommended according to NICE guideline. They do cost-effective treatment and cost-effective investigations. So prolactin not offered as a routine. If any ovulatory disorder, galactorrhea, or any symptom of pituitary tumor, if any symptoms are there, then only you will measure prolactin. Second, thyroid function test, they are not doing as a routine. If the symptoms of thyroid disease is done, then only you will do. Endometrial biopsy, they are not doing as a routine. Okay, so this is also important, because in general practice, these are the routine tests done. So when we do question, usually this mistake is done, but the questions are answered according to NICE. So it is no to routine prolactin, thyroid, and endometrial biopsy. So this part is important to remember and to also understand. Now this is very important. You will get lot of question, and people do struggle with it. Now if you have, for a question has come and you have to find out that what you have to do to visual testing. Now what you will see in the question? Now you have to see if any history of PID is there, any history of endometriosis is there, or previous ectopic is there. That means all of these are the comorbidities. If all these comorbidities are there, then for tubal assessment, directly you will offer the option of lap and dye. Okay, but any other woman where no history of PID, no history of previous ectopic, no endometriosis, that means there is no comorbidity, then in that particular situation, what you would offer is a test of HSG. So people make mistake here, because for every question they mark option as an HSG, but it is not according to NICE. According to NICE, please look at the comorbidities. If you find comorbidities there, then answer would be lap and dye. If there is no comorbidity, answer will be HSG. Apart from this, what they recommend, if the facilities for high COSI or hysterosalpingo-contrast ultrasonography is there, then that is considered to be the best alternative. And again, that will only be done if if comorbidities are not there. So in HyCoSy, the tubal testing is done under ultrasonographic guidance, okay, not under X-ray exposure. So they will not get any exposure to radiation also. And not from the this guideline, but as a clinical practical experience, if you are doing a HyCoSy, so you are seeing the everything on the scan, so you can assess the condition of ovaries, and also you can assess the uterus, triple line, everything can be assessed. Okay, so just this is just in general practical tip why HyCoSy is better than HSG. But again, this is not written in the nice. This just I'm speaking. Now coming to viral status, again, the woman, if you have got a patient, like in your questions, if she is going for IVF treatment, then only HIV, hepatitis B, and hepatitis. For all women, they are not doing this viral marker. So be careful for that also. And if and like this is the human embryology and fertility assessment, that is the HEFA, that controls everything in fertility clinics in UK. This is the according to their guideline, their guideline, that before IVF treatment, these viral marker has to be done as a baseline. Why it is important, I'll just tell you, because if the treatment is done with a donated gamete, so with the donated gamete, they can acquire some infection. So they just want to do this test as a baseline. So it will be worthwhile remembering for 2 and 3 both people. Now, if you are getting a patient and hepatitis B and C is positive, now donors, if it is he is positive, then what you will do? You will refer her to specialist advice. So now you can see, like every like for many things they are doing referral. They are not doing taking all responsibilities to teach to take their patient like themselves. Now another situation, if the patient has come and the hepatitis B is there, they have got one of the member of the couple have got hepatitis B positive. So what you will do, and they have come for the fertility treatment. Answer: offer vaccination. Okay, offer vaccination. So you may get this as a stem of questions as well. Apart from this, another situation can come that male has hepatitis C. What you will do? So though the risk of transmission with the unprotected intercourse for hepatitis C is very slim, very slow, low is there. But again, a better idea would be to eradicate this hepatitis C. So he has to be referred to a specialist hepatologist before conception. So the complete treatment of hepatitis C is done. Now, this part is really important, and you will get lot of questions from here, like risk of transmission. What they say now, risk of transmission to female, if the male is HIV positive and female is not, and this couple they want to get looking for fertility. Okay, so what is the criteria that female that can be there so that they can have sex during during the fertile period? So what are the criteria? If the man is compliant with highly active antiretroviral therapy, so he's a compliant patient. Second, we have done a viral load, and viral load is less than 50 copies million, more than 6 months. So you have to remember this 6 months, because here in this, as at this particular area, they will write 3 months, they will write 12 months, and you usually get confused and put this answer wrong. So please remember, it is a viral load less than 50 copies for more than 6 months. Okay, there should be no other infection. Why it is important? Because if other infections are present, they usually increases the transmission rate of HIV. And unprotected intercourse has to be limited at the time of ovulation. So if these are the four criteria, if these four criteria are there, then female partner is allowed, is very like negligible risk of getting HIV through unprotected intercourse. So these criteria you have to remember. Second situation, man is HIV positive, he is not compliant with HRT, or his viral load is, is more. Then what you will do in that particular situation? You will not allow them to have unprotected sex, because this woman will be at risk. What you will do? You will offer sperm washing. Okay, you will offer sperm washing. And another situation, if any unpredictable risk of transmission is there, then again you can consider sperm washing. Now this offer and consider is like, you already know. Now, sometimes something will be offered, sometimes something will be considered. Offer means that is definite thing. Like if it is not compliant with the HRT, heart, then in that particular situation, you have to recommend, you have to offer sperm washing. Another situation, you're not clear about that there is a possibility of HIV transmission is there. So if you are not sure, then you can consider, okay, sperm washing. And if the HIV negative woman is there, then it is not that, you use of pre-exposure prophylaxis you will give them. Okay, so it is not recommended. So this all things you have to know it very well. Why it is important to know? Because you will get question from every line, you will get question from every line. So better understanding is important. So now coming to susceptibility of rubella, they usually everyone they are offering rubella testing, but these and if the woman is susceptible to rubella, so they offer vaccination. You will get question from here. If the rubella vaccine is given, they can't get pregnant for 1 month. So you will get question from this 1 month part of the line, because you already know that rubella vaccine is a live vaccine. So after live vaccine, they just want to wait it for 1 month before she allowed to go ahead with the pregnancy planning. Coming to cervical screening, the cervical screening is not, it is according to the NHS cervical screening program. Additional screening, additional thing for fertility sake is not done. Now coming to chlamydia, what they say, if a woman is going for uterine instrumentation, in that particular situation, either they will be offered screening, and if positive, then she and her partner will be treated. But if the screening is not done, then in that particular situation, they can consider giving them prophylactic antibiotics. Okay, so like this part you have to remember what they say. So till here, what are the investigation is required according to NICE for male and infertility, I have just spoken. So any one of you have got any question till now that is not able to understand, can just ask me before I move ahead. So any questions? No question. Okay. Then okay. So causes for male infertility. So male infertility causes, they are divided into three parts. So it is pre-testicular, it is testicular, and post-testicular. So what pre-testicular causes? So this is the table from 2013 talk. Okay. So main causes for male infertility: pre-testicular, hypothalamic. If it is hypothalamic, it is Kalaman syndrome. Gonadotropin deficiency. If it is pituitary causes, so all these could be there. Okay, pituitary tumor, radiation, surgery, hyperprolactinemia. Apart from this exogenous hormone, so most common times, you will find anabolic steroid. So these males are taking anabolic steroids that will cause pituitary suppression. Okay. You have, like before lap and dye test, 2 of STA. So okay, so for before lap and dye test or before even hysterosalpingogram, so there would be risk assessment. So they will do screening. Okay, either they will do screening. If they find the test positive, then they will offer them antibiotic prophylaxis. And if the screening is not done, then in that particular situation, they will give them antibiotics. So it is not routine that before every procedure they will be giving antibiotics. Okay, IUI, this thing is just coming, Nivedita. Too much is left. Now coming to causes for male infertility, like what just so the what you have to remember is this number. So pre-testicular causes is less than 1%. Okay, just remember this number. Now coming to male infertility causes testicular, it is 66%. So maximum number is the testicular causes. Okay, that you have to remember. Apart from this, what could be the testicular causes? It could be genetic, Klinefelter syndrome, Y syndrome, microdeletions, Noonan syndrome, male Turner. Okay, Noonan syndrome is male Turner, 45XO, cryptorchidism, acquired will be injury, torsion, trauma to testis, varicocele, systemic therapy, systemic disease, chemoradio, testicular tumor, and idiopathic. And out of these, idiopathic is the most common. Post-testicular, it will be obstruction, like it could be congenital cystic fibrosis, it could be acquired vasectomy, infection, vessel injury. Disorders, so this will be post-testicular. So apart, sexual dysfunction, erectile dysfunction, ejaculatory dysfunction, and usually erectile and ejaculatory dysfunction will come with diabetes mellitus because it causes neuropathy, multiple sclerosis, and spinal cord and pelvic injuries. And this will count for 41% of the people. Okay, 41% of the people. So remember this number: pre-testicular 1%, testicular 66%, post-testicular is 41%. Okay, now like there are two things I would like to say. So this is the male infertility nice recommendation as a treatment. Now next, like upcoming slides, I'll be speaking about the TOG also. So I have made them that separate because you have to know what is the answer and what are the nice recommendation, because nice recommendations are different. Okay, little different. So now what is the treatment for male infertility? So if the man is having hypogonadotropic hypogonadism, hypo means pituitary, like gonadotropins are also low, testicular hormones are also low. So what will be the answer? NICE recommends offer gonadotropin drugs. Okay, so for these males, you can offer gonadotropins drugs. This is a nice recommendation. Please understand, for any other reason of male infertility, what they are saying, no to anti-estrogen, gonadotropins, androgen, and bromocriptine. So it is no to systemic steroids. In the case of anti-sperm antibodies, no to antibiotic if the leukocyte are, if they have given a semen and the leukocytes are count are high. So you will not offer any antibiotic. So these treatments are no treatments that you have to remember, because you will find this in many stem of your questions. Apart from this, what is the like surgical management for male infertility? Now, if the obstetric like some azoospermia is there and there is obstruction, okay, so in that is what you can do. Like surgical correction can be done. Okay, so they can do some surgery of anastomosis, so surgical correction of epididymis blockage, but this is one option. Another option is surgical sperm recovery. So surgical sperm recovery, you already know many techniques are there: epididymal sperm aspiration, that TESA, MESA, what are so many techniques are there. So either that can be done. So if a patient you find in your station is obstetric azoospermia, so there are two options, either surgical correction of blockage or either surgical sperm recovery and IVF. Okay, now you will find this as a question like varicocele. So what the NICE recommends, there should be no treatment for varicocele because it is not improve for improve pregnancy rates. Now if you go to many talks are also there, though these talks are new, but the answer will not come from talk, answer will come from NICE guideline only. So do your NICE guideline recommendation by heart, because that will give you answer. Now another situation, if ejaculatory failure is there, then again what you will do, the sperm retrieval has to be done, and as assistive reproductive procedure has then consideration for assisted reproductive procedures. So either it could be, if the sex is not possible, either it would be with II, IUI, otherwise for all other thing it will be with IVF. Okay, so this is the, like this you have to, this is a little small summary, and that is from the NICE recommendation. But just understanding this will, you know, help you answering your many questions of male infertility. Any questions about it?
Ma'am, can you please explain the previous slide, just the previous one, hypogonadism, yeah, this one.
So male infertility, if the patient is having hypogonadotropic hypogonadism, that can only happen if, you know, like that hypothalamus or pituitary causes are there. So if you find your question where you will find patient is having low FSH/LH and low testosterone, that means both hormones are less, then answer will be, you know, giving them gonadotropin drugs. That is, they can be stimulated with that FSH, or they can be given that HMG. Okay, so this is the only one treatment they recommend. Rest any other male infertility, they are not giving any anti-estrogen. Like for example, in the routine practice in many areas is giving clomiphene citrate to male. Okay, that is anti-estrogen, but it is not recommended by NICE. So you have to understand, there is no recommendation for any anti-estrogen, gonadotropin, androgen, bromocriptine for male infertility. There is no steroids like should be given for, if you find a patient that test result has come for anti-sperm antibodies, and if you find leukocyte count in the semen, there should be no treatment. I would here tell you what is a normal leukocyte count in the semen, that is 1000. Okay, so if you find it more than 1000, that means that there is a increased leukocytosis, that is the leukocytosis number is increased in the semen, but you will not give any antibiotics. Is it clear now?
Yes, ma'am, it's clear.
Okay, so what the NICE recommends for the female infertility, now they have classified the ovulation. Ovulation we already know, group 1, 2 and 3. What is group 1? It is again hypo. Okay, hypothalamic pituitary failure is there. So if from the, you know, hypothalamus and pituitary no hormone is coming, ovary, how they will work? So it will be hypo, that means both hormone will be less. Your FSH, LH and estrogen, all hormone will be less. So this is hypo or group 1 type of disorder, ovulatory disorder. Group 2, everyone knows, this is HPO dysfunction. Like there is a dysfunction of the axis. Where this dysfunction of axis occurs, it occurs in PCOS only. That is the most common cause you will find. Group 3 is again when the ovaries are not working. That means ovarian failure had happened. In this kind of patients, you will find FSH will be very high. Okay, in this if the ovarian failure like we find in menopause, so FSH will be very high and estrogen will be low. Okay, so these are three groups according to like NICE. Now, according to NICE, what is the WHO one ovulation disorder? What you will do? Offer as a treatment. So usually, if the BMI is less than 19, because they are, doing, they are some eating disorder, anorexia. All this will come in this group only. So your answer would be to increase weight if BMI is less than 19. Apart from this, if they are doing too much of exercises, they are athletes, so they have to moderate or limit the exercise level. So this would be the answer. Okay, then what could be the treatment done for, again, hypo. Okay, so treatment for hypo female is pulsatile administration of gonadotropin releasing hormone. So you have to remember this word as it is, pulsatile administration of gonadotropin hormone release, because we already know that gonadotropin in normal conditions, the gonadotropins, they are never released at a continuous state continuously. There are some pulses, it comes in pulses. Therefore, when they are doing clinical treatment, they are giving them pulses of gonadotropin release hormone. Fine. So apart from this, if they are giving them gonadotropins, then they will give gonadotropin with luteinizing hormone activity. So this part you have to remember, because if they give you answer as a gonadotropin or gonadotropin with luteal hormone activity, so answer will come gonadotropin with luteal hormone activity. Okay, so this you have to, and just remember as it is, because you will find similar kind of option even in the exam. Now, most of the women, what we will be seeing is the group 2 ovulation disorder. So if usually these women in PCOS is there, PCOS the BMI will be more. So what you will say? You will just say lose weight. Many of your question answer will be only to lose weight. Now, if you have to offer them treatment. So what you will do? You will do ovulation induction. Okay, and what the ovulation induction they will drug they are using, it would be clomiphene citrate, or they will be using metformin, or they will be using clomiphene or metformin together. Okay, so this is the usually their medication they are using for ovulation induction. Apart from this, what they are saying that ultrasound monitoring has to be done at least for one cycle. Why? Because we have to, we have to have a evidence that this clomiphene is working. Apart from this, that would also have a risk of multiple pregnancy. And if one cycle they have already found out, yes, the ovulation is being ovulation is getting the ovulation is evidenced, then they can use clomiphene for 6 cycle. The NICE doesn't recommend more than 6 months of clomiphene use. Okay, so it has to be limited to 6 months only. Metformin usually have a side effect, that is the nausea, vomiting, and other gastrointestinal disturbances. Okay, so you will find a number of questions from this slide, and answer will again come from the NICE only. Now, if the patient is resistant to clomiphene citrate, that they are not treatment is not working for them. So what will be your second line? What will be second line? It would be it would be first option. What they are saying is the laparoscopic ovarian drilling. Okay. Second option will be combined treatment of clomiphene and metformin if they have not taken it before. First line. Third will be gonadotropins. So this is the same hierarchy you have to know, and in the same hierarchy answer will come. Okay, so with the if the laparoscopic ovarian drilling is done, usually you already know what they do in laparoscopic ovarian drilling. They will just cause a puncture, and that will decrease the tissue that produces androgen. So there will be correction of the hormone milieu or microenvironment inside the ovary, and self restoration of ovulation will happen. Apart from this, what they say that we already know PCOS, it is there's so many follicles are present, And if gonadotropins are given to these PCOS patients, then what will happen? So there will be very high chances of OHSS. So what they want to PCOS patient, actually gonadotropins should not be offered, should not be offered with gonadotropin releasing hormone agonist, okay, because there will be hyperstimulation of the ovaries. Apart from this, they don't want any adjuvant growth hormone treatment, because it will not increase the pregnancy rate. So there is no growth hormone treatment is recommended by NHS. Now coming to ovulation monitor, like if gonadotropin is given to any patient, so in that particular situation, there are two risks we already know. One risk of multiple pregnancy, another there is a risk of OHSS. So what can be done? It can be done ovarian ultrasonographic monitoring is done. So they will monitor the follicular size, number of follicles, and also they will that will help in reducing the multiple pregnancy and also the risk of OHSS, because if they find that ovaries are hyperstimulated, so either they will do cancel they will do some posting, or they will cancel the cycle. So this way the monitoring with the USG, usually the monitoring is done. Now coming to with a woman having ovulatory dysfunction due to hyperprolactinemia, then they are offered a treatment with bromocriptine. So like for every woman, they're not giving bromocriptine. So they have to evidence that prolactin levels are high, then only bromocriptine will be offered. And this is a dopamine agonist. So you will find many questions where prolactin levels are rise. Usually prolactin levels has to be repeated. One time test cannot, because it is affected by sleep, stress, so many factors. So if a one time prolactin comes high, they repeat the test after and if it is confirmed that the prolactin levels are high, then the treatment, first line treatment, it will be dopamine agonist, that is bromocriptine. Now you will find a number of questions from this also, now if the tubal infertility is there and if it is a mild tubal disease, then what they say, going for tubal surgery will be more affected than going for no treatment, okay. Then there could be two things, either there will be problem at the proximal part of tube, or there will be problem at the distal part of the tube. If the proximal is there at the proximal, if the problem is there at the proximal part of tube, then what you have got options, either selective sulfingography plus tubal catheterization can be done, okay, or consideration for hysteroscopy and tubal cannulation can be done. So these are the two. So if you find in your part 3 stations, or if you find in your part 2 questions, if they give something such a Cornwall block, or if they say some proximal tube obstruction, your answer will come towards the selective sulfingography and tubal catheterization, or hysteroscopic tubal cannulation, okay. Yeah, I'm sure that you people might have seen this, how it is done. So apart from this, if the distal tubal disease is there, usually what happens, if there usually there in the distal tube, these fimbrias are there. So either there will be agglutination of fimbria, so they will stick together, and there will be pent up of secretion inside the distal tube. So there will be hydrosalpinx, okay. So if the hydrosalpinx is there, you already know that tubal functions are already hampered. So what the treatment you would offer? What the treatment you would offer is selfingectomy followed by IVF. And why we are doing selfingectomy? Because if you do it before IVF, then it will improve the chances of live birth. Now why so? Because in the hydrosalpinx, that fluid is there, that is infective fluid is there, and if it is not clipped, if it is not removed, then it will be keep coming, and it will be embryotoxic to the like IVF baby. So therefore the treatment is going for self-ingectomy. Preferably, yes, it is by laparoscopy before IVF treatment is done, because it will improve the chances of live birth. So like I try to make the things very simple, so your answer like you will be able to do your question answer without any problem. Now what is the recommendation for uterine surgery? If Asherman syndrome is there or intrauterine adhesions are there, what would be the treatment? Or hysteroscopic adhesolysis, because it will restore menstruation and it will improve the chances of getting pregnant. Now this is real important, and many questions will come from only from this slide. So this you have to understand very well. Now like if unexplained infertility is there, that means they will give a question where semen is normal, tubes are patent, woman is ovulating. All three things are doing well, and then it is an unexplained infertility. So what you should do? What you should do in the answer recommended by IVF, recommended by by your NICE guideline. If the unexplained infertility is there, like in that particular situation, you have to ask this woman to try naturally for 2 years of regular unprotected intercourse, and after 2 years, if there is no pregnancy, then please offer them IVF treatment. You will this part has to this lines are very important to understand, because you will find questions from there only. Okay, many questions from this line you will find. What is like what we do in our practices, we usually do ovulation induction and we give them clomiphene. Therefore when we do answer, we take that answer, but it is not. For the part 2 and part 3 MRCOG, we have to do answer according to NICE. Please don't bother about any book, don't bother about any talk, answer from NICE, then only your answer will get correct. So guys, if it is unexplained infertility for 2 years, please send this woman for IVF. Okay, don't make mistake here.
Excuse me, ma'am.
Yes.
Ma'am, in certain question, it already says that the couple is trying for 2 years, or they are suffering from subfertility, everything is normal from past 2 years, and they are 34 or 35-year age. Then we have to immediately send the couples to the IVF, or we have to ask for again 2 year of unprotected intercourse.
No, it is 2 years of unprotected intercourse. After, if they have done 2 years of intercourse, that is unprotected, and on the investigation there is no reason for infertility, answer would be IV.
Okay, ma'am. And irrespective of age, ma'am, if they are very early young couples, so we have to ask them to continue, we'll give some more time, or straight away we have to send.
There is no age criteria according to NICE. No age criteria according to NICE. Okay. Early age, there is no such criteria. But if your patient is 36 years, more than 36 or more than 36 years of age, then you will fasten the treatment for her. The reason you already know. Okay. Under this thing you have to understand, and this will get more clear when we do questions, because I have put lot of questions also. Okay, again you have to understand this. There are only 3 indications. Remember this. There are only 3 indications for in IUI according to NICE. If vaginal intercourse is not possible, number 1. If the people in same-sex relationship, number 3. If like any specific consideration is there, like sperm washing is required in case of HIV positive, because you can't allow them for intercourse. Okay, so there are only 3 conditions where IUI will be the answer. Okay, for unexplained infertility, Nivedita, this is your question and answer. For unexplained infertility, don't offer any IUI to them. If they have unexplained infertility, people tried for 2 years, refer them to directly for IVF. Okay, so don't make mistake. There people do this mistake. And IUI indications are 3. I'm repeating it again. Vaginal intercourse cannot happen, same-sex relationship, and other medical treatment. For example, sperm washing is recommended for HIV. There are the only 3 indications for IUI. So whenever you have to put your answer as an IUI, please see if all this is coming or not. Okay. Apart from this, if the 6 cycles are not done, if the 6 cycle of IUI they have done, still no pregnancy, so you will ask them to go for 6 cycle more. So after 12 cycles of IUI, after 12 cycles of IUI, this couple will again be referred for IVF. Is the thing clear? Because people make mistake here. Is it clear about the IUI indications?
Absolutely. Absolutely.
Now again, this you will get 100 questions from this slide only. So now, if your patient has got unexplained infertility, what I have already explained, if your patient has got mild endometriosis, if your patient has got mild male factor infertility, I have already spoken about mild male factor infertility beforehand. Okay, I have already explained that what is mild male factor infertility. That is one parameter is less than 5th centile, okay, according to WHO criteria, what we just read. If you find 3 indications in your answer, or part 3 people, if they find these 3 indications in their station, please, you need not to offer any routine IUI to this patient, okay, with or without stimulation. But the exceptions are there. If the intercourse is not possible, okay, then you can't help it. Then you can't help it. If if they have got religious, social, or culture objection to IVF, then you really can't do anything. Then you have to give them IUI. But I have never seen a question like that they will have any objection to IVF. So in that particular situation, you will not unnecessarily offer any IUI. Just ask them to try for 2 years. Then you have to refer this patient for IVF. So again, these 3 indications: unexplained infertility, mild endometriosis, mild male infertility. Answer: wait for 2 years, try naturally, no pregnancy, refer for IVF. So you have to understand, because you will get a scenario in the stage, in the question. Then if you don't clear the scenario and put that in according to NICE, then you will going to do your questions wrong. So these are 3 indications where you will ask women to wait for 2 years, then send her to IVF. Now, what are I have seen one question from this also. What are the predictors for IVF success? Female age, that you already, everyone knows age is a big factor for women. Apart from this, if the previous live birth is there, okay, then the chances of IVF treatment being more effective is high. But if previous failures are there, then usually chance of live birth falls. IVF success BMI has to be in 13 to 19 to 30, and if the outside this range BMI is there, that reduces success of ART. Now this lifestyle modification for IVF, okay, for IVF it is different. So now what they say, consumption of 1 unit of alcohol even reduces it. So what they want, ideally they should not take any alcohol. What they are saying, both maternal and paternal smoking, it reduces the success of IVF. Here, even the maternal caffeine has got adverse effect on IVF. So these are the lifestyle for IVF. These are different from the lifestyle modification when the couple is trying normally. So remember them separately. Otherwise, in the exam, questions will become very confusing. Now this again coming to IVF, what the nice recommendation is, what is a full cycle? So full cycle is one episode of ovarian stimulation and transfer of any resultant fresh or frozen embryo. Okay, so this is the definition for IVF cycle. Now, what is the criteria? You already know that for the IVF there are certain criteria are there. These are age-based criteria, and some other criteria are there. I would be discussing that will help you in answering your question. Now, if the woman is under 40 years of age, and then and if like the 2 years of unprotected intercourse is there, and then in that particular situation, if you are referring them for IVF, actually 3 full cycles of IVF with or without ICSI will be given to her. But if during treatment, now you start a treatment of a patient at 39 years of age, you started with IVF, and in between your IVF treatment, her age becomes 40. Then you will just do the current cycle. You will not offer her other cycles. Okay, so this part is also important to understand. So it is what they are doing. It is according to age. Less than 30, 3 full cycles. Now, what will happen to 40 years old woman if she is 40 or 42? So if the woman is more than 40, and like in this category the female is there, then they offer usually 1 cycle of IVF with or without ICSI. But these are the criteria in those women. They should not have any previous IVF treatment. There should be no evidence of low ovarian reserve. They should understand what are the additional implications of IVF and pregnancy at 40 years of age. So this you have to understand, like that they should not have any previous IVF, no ovarian reserve volume, no additional. They should understand what can happen to their age, to their health because of IVF and pregnancy if they undergo treatment at this age. If these 3 criteria are met, then only 1 cycle will be offered to them. Now, this is important. You will get this in the exam also. You have to remember this. Ovarian reserve testing. Now you see ovarian reserve testing, why we are doing it. So usually ovarian reserve testing is done when the woman is going for IVF, because in that particular situation you have to find out how will be the response and how successful will be the cycle. So what I want to say, routinely they are not doing all these tests that I have already explained you. So what will be the criteria or test they are doing to to check for the ovarian reserve? There is the enterical follicular count. If it is less than 4, it will be a low response. More than 16, it will be high response. AMH less than 5.4 picomole per liter. Just remember this value of picomole per liter, because in our countries we are not using this picomole, so you will do mess up with these values. Okay, so if it is less than 5.4, it is a a response will be there. If it is more than 25 picomole per liter, high response would be there. So and for FSH it is reverse. Okay, FSH is more than 8.9, low response. Higher than 4, high response. Sorry, less than 4, it will be high response. So these are the criteria that you have to remember. All these numbers are important because they are directly given in the questions. And if you don't remember these numbers, you can't answer. Okay. Now, what is the main issue that happens if they go for IVF? Usually there is a premature LH surge is there. So that will, destroy their destroy the cycle. So what the NICE recommend? So there are 2 protocols we already know. One is the agonist and another is antagonist. So what they want, if the patient is going for agonist protocol, so they have to use like long down regulation protocol. So if agonist protocol, to avoid LH surge, they have to use long down regulation protocol, or if they are not using agonist protocol, they should go ahead and they will use antagonist protocol. So these are the two ways they would be able to prevent that premature LH surge. Okay, so they will be able to produce this much of prevent LH surge. So now when they are doing IVF, so they usually they will be offering them FSH. How they will decide how much FSH is done? It is decided on the basis of age, BMI, presence of polycystic ovaries, and ovarian reserve. Okay, so these are the four factors that will help in deciding how much dose of FSH has to be used. Now they do have a limit also. It can't be used more than 450 IU per day. Okay, and ultrasound monitoring with or without estradiol level has to be done. Okay, apart from this, what they recommend, not to use any growth hormone or not to use any DHEA. Okay, no growth hormone, no DHEA. Now what the trigger they are advising, trigger would be HCG, it could be urinary or it could be recombinant. Okay, and ultrasound monitoring has to be done, because with the ultrasound monitoring only we'll be able to find out whether the ovulation had happened or not. Now what the NICE recommend for oocyte and sperm retrieval in IVF, what they say, it can be done in the conscious sedation. It is a safe and acceptable method of analgesia. Okay, that means you will give some analgesic and some sedation to this woman, but she will not be sleeping, she'll be awake. Apart from this, what they recommend, if the three follicles like have developed, like if they have developed less number of follicles, if it is like 3 only, then follicle flushing should not be done, because it will only increase the pain, it will not increase the pregnancy rates. Apart from this, so this is for the females. For the males, if they are doing surgical sperm recovery, like all this TESA, MESA, all this extraction or aspiration technique from testis or epidermis they are doing, in that particular situation, it should be done at the center where the facilities for spermata cryopreservation of sperms should be there. That is quite understandable. Why I will do a sperm biopsy today if I'm not able to, store the sperms? So it should be done in the centers where cryopreservation facility is there. For like IVF, they don't recommend any assisted hatching. Now these are the criteria what they have given, for embryo transfer. So it has to be USG guided, that we already know. Thickness minimum ET should be like 5 or more. Less than 5, you already know, that implantation will not happen. Bed rest of 20 minutes. Okay. So apart from this, they are judging the embryo qualities. So how that is just judged on the basis of cleavage and blastocyst stage, and that is according to Association of Clinical Embryologists and UK NECAS for reproductive embryology science. So you have to just remember this UK NECAS and ACE, because sometimes this question can be asked. Okay. Apart from this, one time I have seen a question like, what is the best sort of a technology with which you can find out the embryos are done very well developed. So in that question, answer was time-lapse technology. Okay. Now this again a very important issue that you have to understand. So right now, what we have learned is the according to the age, number of cycle, that that NHS like nice offers. Okay, now coming to embryo transfer. So this is again based on age. If your patient is less than 37 years of age, we already know three cycles are given. First cycle, it is single embryo transfer. Second cycle, you will try to do single embryo transfer if you have got top quality. If it is not there, then two embryo transfer. In third cycle, always two. In third cycle, always two. Okay. So I'm repeating it again. 37, first cycle, single embryo transfer. If it is in second cycle, one embryo transfer, single embryo transfer, SET, if top quality embryo is there, but you don't have good quality embryo, then you can transfer two. In third cycle, it is always two embryo transfer because this is the last cycle. Now, coming to women in between 37 to 39 years of age, in first or second cycle, they want to put one embryo if it is top quality, but if it is not top quality, then it will be double embryo transfer, and it is in third cycle for everyone, it is double embryo transfer. Now, for a woman who is 42 to 42 years of age, you already know that only one cycle will be offered to this woman. So in that one cycle, double embryo transfer is done. Okay, you will find question from this one. Now the embryo transfer, what you are doing, it is not depend. It usually depends upon the age of egg donor. Okay, so whatever the calculation is done, it is done from the age of donor. What the NICE recommends not more than two embryos should be transferred. So they are transferring only two embryos. And if you get top quality embryo, please do a single embryo transfer. Now, if in a cycle good embryos are formed, then cryopreservation, they should be preserved. Now, this is very important question. Like I have not seen in MRCOG anywhere they are offering luteal phase support or progesterone as a treatment. Only one indication that IVF is done. Then for luteal phase support, they are offering progesterone. That too, they offer like 8 weeks till 8 weeks of pregnancy. So luteal phase support for IVF, progesterone till 8 weeks of pregnancy. Now, few things about this genetic issues and counseling. So, usually what they say before ICSI, before ICSI, they should go for appropriate. Why ICSI is offered? ICSI is usually offered in severe male infertility. Now, why the severe male infertility is there? There could be a problem with some genetics, okay, that you have to understand. So before ICSI, there should be discussion about implication of treatment. They should be referred for genetic counseling and testing. And if it is a severe deficit or on non-obstetric azoospermia, very severe problem. So it will be in severe deficit of semen quality. Consideration of main karyotype should be done, because sometime problem with the karyotype will happen. Apart from this, routine test for Y chromosome micro deletions are not done. Okay. Then why the ICSI is offered? Because it improves the chances of fertilization than IVF alone. Now this part you have to till now whatever we were discussing, it was in some, if IUI is there, it will be with their partner semen. But there could be some situations where they have to take semen from outside, or they have to go for donor insemination. So what are that indications? Obstructive azoospermia, non-obstructive azoospermia, severe deficit in the semen quality, and they don't wish to go ahead with the ICSI. They have got semen in the semen is there, but they don't want to go ahead with this ICSI. So they are left out with one treatment, that is going for donor insemination. Apart from few other conditions also, where donor insemination could be done. What are they? If there is a high risk that risk of transmitting genetic disorder is there, when there is a high risk of transmitting infectious diseases there, when there is a severe Rh isoimmunization. Okay, so if the woman is ovulating regularly, 6 cycles should be offered. But if after 6 cycles she is not getting pregnant, then tubal assessment should be done after 3 cycles of donor insemination. Okay, so this part is different in donor insemination. They are checking her tubes after 3 cycles. Oocyte donation. Why the oocyte donation is done? Premature ovarian failure, gonadal dysgenesis including Turner syndrome, oophorectomy has been done, chemoradiotherapy has been done, treatment failures, okay? All the time there have been treatment failures, and there is a risk of transmitting a genetic disorder. These are the indications for oocyte donation. You will find in both part 2 and part 3 questions. Now for the oocyte donors, what they say, usually there are criteria are there in UK for sperm donor and also for oocyte donor, but I'm not speaking about those criteria because they are not given in NICE. So what given in NICE? So oocyte donor should be screened for infectious and genetic disease. There should be implication counseling. They should be explained about oocyte collection and risk of OHSS. Apart from this, there is an egg sharing program where they can, if the extra number of eggs are there, so they can be shared. That will cause the reduction in the cost. So they can participate in egg sharing scheme. Now, cryopreservation, if a patient is going for cancer-related fertility, then in that particular situation, they can go for cryopreservation. But in that particular situation, like eligible criteria for fertility treatment about NHS funding, it will not be uniform, okay? If the cryopreservation, usually for the semen, what they are using, liquid nitrogen vapor for freezing, okay? So you may get question from there. And for the egg cryopreservation, okay, for if like young age women, they are going for any treatment of cancer, then cryopreserve, and they are enough time is there for ovarian stimulation and egg collection. This will not worsen their condition. So they can go for oocyte or embryo preservation. And how it is done? It is done with a vitrification. Okay, so for egg or embryo, it is vitrification. How much time the preserved material is stored? That is for the 10 years. And if for the sperm, if the patient is going to be infertile more than 10 years, then more a number of years this preservation can be continued. Now there long-term effect of what the NICE guidelines says. Long-term effect of fertility treatment. So there is though it is very absolute risk is low, but there is but small increased risk of borderline ovarian tumors cannot be excluded. Okay, so this question I have seen in the exam. So here, that's all full thing about the NICE guideline. So any one of you have got any question can ask me. Otherwise, I'll be discussing male infertility.
Ma'am, that with gonadotropin down regulation part is not clear.
So
questions are asked.
Yeah,
but
so
concepts
usually there are two type of protocols are there. I will not be discussing too much about the protocols because maybe I'll be taking assistive reproductive class next whenever I have time. So all these protocols will be discussed that time. That is there in the 2017 talk. But what is what NICE is, I'll just speak about that again. So usually what can happen that when they are using this gonadotropins for like IVF treatment, so what happens that premature LH surge may happen from the body itself. Now that will cause ovulation, and they don't want ovulation that time. Maybe the egg is not mature or something. So they want that premature LH surge should not happen. So what can be done to prevent that LH surge? Now there are two criteria. If they are using agonist criteria, in that agonist criteria, they are asked to use long down regulation protocol. What happens in that long down regulation protocol? Like from the previous cycle, they started down giving them gonadotropin. They started them like down regulation, and this is one thing. Apart from so this is if the so they recommend if agonist cycle they are going, they should use long down regulation protocol. Second, if they are not they don't want to go for such a long big cycle, then they will be going for antagonist protocol. So instead of using gonadotropins, they will be using antagonist. So antagonist cycle will be there.
Okay, ma'am. Understood.
Now coming to male infertility, because I had to cover this with the NICE, and this updates will be from strategy and from the talk. Okay, whatever I'm speaking from now onwards are the updates from talk and strategy. NICE part has been finished, so you have to understand that. So history question for male infertility. It is important because male infertility station comes in part 3, and candidate they are so they mess up with the history. So you have to what the questions, what has to be asked: developmental details about the puberty, change in the changing in the shaving frequency or loss of body hairs, infection, any STD, any mumps, any prostatitis that comes under infection only, any surgery for hernia, for varicocele repair, hydrocele repair, vasectomy, drug and environment, any alcohol use, smoking, anabolic steroids, chemotherapy, exposure to toxic chemicals, radiation, recreational drug. It is important to take sexual history, that will be libido, frequency of intercourse, previous fertility assessment, previous proven any fertility. Okay. Apart from this, once the history is taken, then what will be the another part? It will be the examination part. So what is the examination done? So if it is increased if there is increased fat and decreased muscle mass, so that would suggest androgen deficiency, or like any testosterone deficiency or androgen deficiency is there. Now if the skin examination is done, if there is an androgen deficiency, so there will be lack of pubic, axillary and facial hairs, there will be lack oiliness of skin, there will be fine facial wrinkling. Apart from this, they will say is go for external genitalia examination. So they will check for scrotum to find the absence of vashes there. They will check for any epididymis enlargement is there, or any varicocele is there. Okay. Now they will check for the testicular size. Testicular size assessment is done with the orchidometer. So if the testicular volume is less than 15 ml, 15 ml, then it is considered to be small. Need to check for hernia. Need to check for gynecomastia. If the breast gynecomastia is there, that means there is an increased estrogens are coming from in the body from somewhere. Incomplete sexual development, such as they have to examine the phallus and testis. Endocrine test, like what are the endocrine test that has to be done? So this endocrine test, first, like this I have already said. So if you find some abnormal parameters in the semen, so you have to do repeat test. So repeat test has to be done after 3 months time. But if severe oligospermia or severe or azoospermia is there, in that particular situation, they will do repeat semen test, and that they will do as early as possible. Now the result for repeat semen test also indicates the azoospermia or severe oligospermia. Then the next step, what they have to do, they have to go for endocrine test. So these are the endocrine tests. These are basal FSH, LH, testosterone and estradiol levels. This you will find this in many stem of the question. Therefore, understanding is important. Though NICE has not said anything about it, and this update is from the strategy and also from the 2013 talk, but this helps in answering your question. So this will be the indications and of the endocrine test in the male infertility, and why the male infertility, and what are the male endocrine test in the male infertility is done. Then I try to simplify the things because you will get a lot of question from there. Now understand, FSH and testosterone. FSH usually comes from pituitary. Everybody knows. Testosterone comes from testis. That is also everybody knows. If both are lower or then if FSH is low, testosterone is low, the reason will be pre-testicular. Okay. What are the pre-testicular causes? I have already shown that table. Okay. Now second condition, FSH is high and testosterone is low. So high-low condition. This is high-low condition. So reason will be at the level of testis. Okay. Now we everything is normal. So the cause will be post-testicular. So this is an interpretation table that will help in finding out where is the reason. Cause it as hypothalamus pituitary, it is a testis, or it is post-testicular. Okay. So this you have to understand. Apart from this, now if there will be, you will find question, your patient is on anabolic steroid. Anabolic steroid, it causes pituitary FSH suppression. So FSH will be low. But you, as the patient is injecting testosterone, and there are so many brands are there. So depending upon the brands, their testosterone level may be high, may be normal, or may be low. Okay. So, there is no definite criteria for this, because anabolic steroid is not a single drug. There are so many. Okay. So that will depend on the type of drug. So this you have to understand. Very importantly, you have to understand this. Now another situation, your all hormones are normal, or patient is having like low volume sperm, or like no sperm, no semen is there, or azoospermia or oligospermia can be there. Then you have to just think, what is the issue? All hormones are normal and there is oligospermia, azoospermia, or there are no sperms. Okay. There could be possibility of post ejaculation. Retrograde ejaculation. Therefore, in this kind of patients, if everything is coming normal and you are not able to find reason, then consideration for retrograde ejaculation. So post ejaculatory urine sample should be seen whether the semen is sperms are present or not. Okay. Now what could be the treatment? So this is almost same thing what we have done from the NICE, almost same. But this is according to from the talk. Like a medical hypo, I already told you that there had to be gonadotropin. If it is surgical treatment, now if the patient gives history of vasectomy, reversal of vasectomy, otherwise what could be the surgical thing? It is surgical sperm recovery. Either it could be testicular sperm extraction, or it could be microsurgical testicular sperm extraction, or if it would be epididymal microsurgical technique, or it will be percutaneous. So these like TESSA and MESA, PESA, like what these are the techniques of surgical sperm recovery. Okay. And now this percentage is important. If the patient has a obstructive cause for obstetric cause for male azoospermia is there, then surgical sperm recovery is 100%. In case of non-obstructive cases, the surgical sperm recovery rate will be 50%. Okay. This time is important. You will find question from there. Apart from this, if nothing helps, then what are the options left out for male infertility? It will be IUI. Monthly conception rate is 8 to 16%. This number is from that talk. So, you may find this number important. So, monthly conception rate of with the IUI is 18 to 16%. Another option is going for IVF and ICSI. With IVF and ICSI, 33% rate of the success is there per embryo transfer. Okay. So, this is a sum up, though it is exact same what is written in NICE, but this is a sum up from, 2013 infertility talk. Now, another thing that I would like to discuss is retrograde ejaculation. So, why it happens? Reasons: due to any surgery like any pelvic or autonomic injury, bladder neck injury, or patient is taking some medication such as alpha antagonist. Okay, so these are the reason for retrograde ejaculation. The treatment, drugs will be alpha agonist such as pseudoephedrine that will restore antegrade ejaculation. So this is number one. Another, urine can be collected after ejaculation. Then urinary alkalization will be done. Then after sperm washing and everything, IVF and ICSI would be the answer. Okay. So this will be the treatment for retrograde ejaculation. Yeah, this part. Now if you find that patient is not able to cannot ejaculate, then what you will do? If patient is having problem in the ejaculation, surgical sperm recovery or surgical sperm extraction has to be done. Then after, they had to go for either IVF or IVF ICSI. No, this is the update from 2020 male infertility talk. Many updates are there. Like I tried to sum up here, but these few things, they are not according to NICE guideline. So you have to be very careful. Your all answer about the recommendation will come from NICE only. But I have just put this updates. If any SBA comes from the talk, you'll be in a position to answer it. So 50% of the cases of male infertility are idiopathic or unexplained. Okay. And okay, so this is the this percentage is from this talk. 50% of the cases are idiopathic. Now they have done some update about the lifestyle thing. So what they have said, that obesity is associated with oligospermia and azoospermia. Okay. So apart from this, they have said something about the diet also, like fruits, vegetable, fish, poultry, cereals, low-fat dairy products. They are positive. They have got like good impact or positive impact on the semen quality. But on the other side, processed meat, full-fat dairy products, alcohol, coffee, sugar, sweetened beverages, they are associated with the poor semen quality. Okay, so this is update from the talk. Okay, apart from this, like oxidative stress usually causes sperm dysfunction. It causes damage of cell membrane, impairs semen motility, reduces ability of the sperm to fertilize ovum. So antioxidants can so what the talk says, antioxidant can protect the cell from oxidative stress. Okay, but NICE has got no such recommendations. Apart from this, on the smoking we already said that smoking is associated with the reduced sperm count, motility, and abnormal morphology. And if smoking, if the smoking cessation is done, then that will reduce risk of miscarriage by 4%, risk of treatment failure by 4% by miscarriage. Maybe this number 4% is important. It can be asked in any SPA. Now, what they speak about the alcohol, like more than 50% of the male are taking alcohol. Alcohol consumption affect the semen volume and morphology. Apart from this, caffeine, what they say, this caffeine is associated with sperm aneuploidy, and DNA breakage. Okay, it causes DNA breakage. So you have to know this because you may get this as, in question in your SBA. You can get this in SBA. Apart coming from stress, yeah, stress do have an effect on semen quality, but how it happens? Stress usually causes the rise of corticosteroid level, and this corticosteroid level in turn will causes the suppression of testosterone. Okay, so therefore this way the stress usually affect. Apart from this, sleep is also important because testosterone follow the diurnal pattern of the secretion, and rise in testosterone usually occur in rapid eye movement of the sleep. Okay, so that also do have effect. Apart from this, prolactin secretion increases during sleep. Now, like NICE does not recommend any sperm DNA fragmentation, like any tests are not there, but these are the tests that are recommended by that talk. At least you need to just remember the name of it. Details are not required. So these are sperm chromatin structure assay, sperm chromatin dispersion test, this tunnel test, and comet assay. Okay, just remember the name because they are not recommended by NICE. Apart from this, like standard method for sperm collection in ART treatment is density gradient or swim up. Various technique, like there are certain advances are there in sperm selection. So what they are using is an M-sum. What is this M-sum? That is called, that under the like this much high magnification, they are observing unstained sperm. So 6 organelles has they are assessing. This is acrosome, post acrosomal lamina, neck, tail, mitochondria, and nucleus. Maybe in the exam you will get what is M-some and what are the 6 organelles that they are seeing. Okay, apart from this other test, what they recommend is a hypoosmotic swelling test and magnetic activated cell sorting, MECAS. So these are the few things that has come from that talk, and only too much detail is not required. It's usually not asked in exam. Only if you remember the name, that will be fine. Apart from this could be the question that is that from that talk only. Most common causes of aneuploidy is Klinefelter syndrome, and it is responsible for 11% cases of azoospermia. Maybe you get any question from there. So that's all that I had to say about the NICE fertility guideline and also male infertility. So any one of you have got any question can ask me. Otherwise, now there will be questions. Okay, so this is the question number 1. What is the following statement that is true about the recent change in WHO parameters? Now, these are the 5 options. So, more than 50% have forward progressive motility. Normal morphology 44% is optimal. Sperm concentration of 30 million per ml. Semen volume of 3 ml or more. Complete absence of anti-sperm antibodies. So, what should be the
second?
Yeah.
Second.
Yes, normal morphology of 4% is optimal. Okay, so these are the criteria what we just remembered now. So now you can read this question.
Ma'am, 4.
Yes. So answer is
Terat-
oligoasthenoteratospermia. Now why oligo?
When
Sperm
count is less, concentration is less,
and why
mortality
mortality? So
and
mortality
sperm.
is astheno, and normal form is less than 4%. So it is terato. So it is oligoasthenoteratospermia.
Ma'am, donor insemination.
Yes. Reason?
Ma'am, he's first of all he's having mum, so might be orchitis must have been there, so it is
So okay.
testicular
So
orchitis can be there, so that's why it is not possible. Sperm count will be low. High FSH is there, so primary testicular failure can be the reason.
yes. So FSH, LH are high, testosterone is low. So high low means testicular failure, and karyotype is normal. So like the testicular failure is the reason. Now if the testes are failing, so only donor insemination would be the answer. It's almost the same question we have done.
Oligo again. Ma'am, again it is third one. Oligoasthenoteratospermia.
Yes, so it is oligoacenoteratospermia. Reason we have just explained. Okay, so this was the report. So now what to be done? This is same question continued part 2. Female partner has got good ovarian reserve, tubal patency is there. So what will be the next course of action to this couple?
HCG is Ma'am, IUI.
Why you want to go for IUA? How much is the count?
The count is progressive. Total is 12.4
So
and 20.
it is oligospermia. So if it is oligospermia, so what you can do? In oligospermia, you can give 3 months time, so another test can be done.
Okay.
Okay,
Okay.
same couple. Now they have done that after 3 months, the test was done again, and this is the result. What should be the treatment?
ICSI.
Why ICSI?
Ma'am, again the sperm count, sperm concentration is low in the second.
Yes, so it is sperm count is like it is more deteriorated than before. Okay, so answer will be C. Yes, someone wrote J. Lapendi. Yes. Now you can see from the question, you have to understand that this woman has a day 21 progesterone is 55 and 41. That means ovulation is happening. Semen, if you go for semen is normal. Okay, there is no problem. Like 25 million, so semen is normal. So, like basic thing, whenever any infertility patient come to our hospital, our clinic, so we do what? There are three things we have to check. We have to check their ovulation. We have to check sperm count. And we have to check tubes. So, in this question, ovulation has been checked. Semen quality has been checked. What is left out for the assessment are the tubes. And in the tubes, now according to the guideline, you have to check for comorbid risk factor. If it is any previous infection, PID, ectopic, endometriosis, answer will be Lapendi. Here she has got cesarean section and she has infection. So she has a risk infection is there. So this is one of the comorbidity. So answer will come for Lapendi. Is the thing clear?
Yes, ma'am.
These are strategies EMQ. I at least.
See.
Now the patient is ovulating.
Repeat the test.
Semen is very bad. Semen analysis, like semen analysis, how much? It is 1 million. It is severe male. In severe male, like either we have to repeat it immediately. So and if immediate option is not there, then you have to check for hormones. Okay. So now look for the test. If immediate semen is there,
No, ma'am.
so it would be hormones. Okay. So if it is, so history of chemotherapy, severe oligospermia. So what you need to do, the next step will be doing endocrine test. An endocrine test, it would be FSH, LH, testosterone and estradiol. Okay, but that is not the option. So what is the option they have given? You have to answer accordingly.
Answer will be, ma'am, C.
Why C? These are same day. These are follicular day. So this is for female. You are doing it for male. Answer will be Q. This type of questions you will get in exam. So what here again? So what we need to check? We need to check for this thing. We need to semen has been, so semen is fine. So no male there is no male problem. Coming to female. There could be two. We have to find out. We need to check for ovulation, and we have to check for tubes. Okay. So now coming to ovulation testing. So what is the history? She used to have regular periods, but now she's menstruating every 5 to 6 months. That means she's having infrequent periods. So that means she is not ovulating. So before going for testing, what you will do, you will restore, like you will check, do test for ovulation. Yes, so you have to do, like it is infrequent. You can't do on the on the second or third day of period. You have to do the day she has come. So answer will be C. Is it clear?
Yes, ma'am. Ask them to.
So here there is no sex happened at all. Hymen intact. Yes, sexual therapy and advice. That would be the answer. Now people they get confused whether why not psychosexual assessment and counseling. Like if everything is normal and they're not still they're not able to have intercourse, then psychosexual counseling will be done. But here even the intercourse never happened. So answer will be sexual therapy assessment and advice. It is not infertility question, but yeah, they have given in this domain, so you have to know because it's a strategy question. Now you see here, actually this is not fertility question. I will just help. There is no problem with the sex, and semen is fine. So semen there is no problem. Now coming to ovulation part. Okay, now semen is, if the semen is okay, you have to check ovulation. Now this patient has termination and bleeding. She has been troubled by off and on bleeding. Okay, so they have not given anything that you will check for ovulation, but their cervical smear normal. Like they want to know the reason for this bleeding. Okay, because if this bleeding reason is sought out, then only you can check for then only you will be able. No, the answer R is right. So then only you have to check for ovulation. So basically, what first we check for semen, second we check for ovulation, third we check for tube. So this is, if you like, this is not, it is not written anywhere. I'm just telling you the hierarchy that will help you in answering question. So first in your question, check for the semen. If you find any semen thing, do the answer that. Semen is normal, check for ovulation. You will find something from there, just address that in the answer. If your ovulation is fine, semen is fine, check for the tubes. You will find something regarding tubes, answer that. And if all three things are okay, then you are dealing with the then you are dealing with the this thing. You are dealing with the unexplained infertility. Coming to this question now, see, semen is fine. So after semen, we need to go for ovulation check. Ovulation check we can't do. She is bleeding off and on after termination. So we have to find out why she is bleeding. There is no cervical reason. There is no infection. So answer is termination has been done. There could be GG. Okay. So smear normal, swabs are normal, irregular bleeding after termination. You have to do UPT. That is recommended by your new mole GG. So now you see semen is okay.
L, ma'am. L.
Yes, L. So now you can see semen, his hair is coming well. Now if semen is well, you have to go for ovulation. Now if you see for ovulation, check for her periods, but her Marina is there. So what you will do? Check for Marina. Answer is Marina. Okay. USG. Now here you can see that. Okay, you do your answer first.
Semen is okay. 21st day progesterone is fine. Unexplained. 2 year.
So semen is fine. Go for ovulation. She's anovulatory cycle. It is 25 only. Okay. So now if there had been no ovulation, what you will do?
Ovulation induction.
Yes, clomiphene. Now semen is fine. Go for ovulation check. Okay, what she's having oligomenorrhea. They have done all this hormone. So you have to find out answer from here. What is the problem here?
Type 3 ovarian failure, kind of LH and FSH are raised.
No, how much they are raised? FSH is normal only. What is a normal FSH? It is less than 10. So FSH is okay. No problem.
Prolactin is more. Yeah.
Prolactin is high. So what you will do?
G. This your bromocriptine, ma'am.
But
Prescribe G.
yes.
G.
Before that you have to repeat prolactin. Now LH is more than FSH and oligomenorrhea. Prolactin is high, you have to repeat prolactin. And if the prolactin in the repeat, because prolactin, there are so many variations with the stress, with the time it has taken. So before you offer prolactin treatment, ideally it has to be, repeated, though there is no guideline for it. So you have to repeat it. And in the repeat also, if it is not high, then you have to go for bromocriptine treatment. Now I have already put this prolactin range, we in our countries we know according to nanogram, but in for the exam it comes, they always give you in a international unit. So it is, now you can see I have put the picture. So the normal value of prolactin is in international unit is unit is 40 to 530. Okay, so somewhere 500, like somewhere I have seen this value as a 500, sometimes 600. So if it is more than that, then it is hyperprolactinemia.
Repeat semen analysis.
Repeat semen analysis they have given the option.
Progesterone is no 2020. Anovulatory.
But it
This
has
is
factor
this is,
results.
but they have given that in a picomole. Again, that is an issue. So what? Actually, question is not that complete, but they have tried for 2 years, and it is a severe male infertility. Okay, 8 million. 8 million is the like oligospermia. So ideally, they have to do semen test. If the semen test has not been repeat semen test, then they can go for this thing. They should go for male endocrine test. But these, if that is not there, now this is the question about treatment. So what you will do?
IVF, I mean, with ICSI.
IVF with ICSI should be the answer.
And ovulation is there. And ovulation. Ma'am, an ovulation is there again. Start on clomiphene citrate.
The anovulation is there, but yeah, actually, yeah, this is anovulatory cycles. So answer should be clomiphene citrate. But FSH, but what they have given that FSH and LH values are very high. Okay, so if that much LH is there, so it is like too much high. So the test has been done on day 21. So they want, the answer is they want to do hormone profile in day 2 and day 2 to day 5. Okay, but considering this thing, considering progesterone level, you can think of ovulation, and start with the clomiphene citrate. That could also be the answer. But they have given repeat it on day 2 or 5 of the cycle. Okay, but it sees also like clomiphene, like ovulation induction could also be the answer. That will depend, what they have asked, whether they have asked treatment or whether they have asked investigation. If they have asked investigation, then this will be the answer. If they ask treatment, then this will be the answer. Okay.
Klinefelter syndrome. No, most common is idiopathic.
Yes, idiopathic.
It's 25%.
Yes, 25. You have to remember this table by heart.
Female age.
Female age.
Most frequent used destroy. Ovarian antral follicle count, ma'am?
Most frequent used test. Most frequently used test.
Basic FSH.
FSH. Most frequently. How many patients you will write MH? All patients you will write FSH.
Fallopian tube function. Best is a hypoxia.
Best is a spontaneous intrauterine pregnancy.
Oh.
Therefore, this gives you message that you have to read all options carefully. Don't see the first or second option and answer.
30%.
Yes.
Laparoscopic self-injectomy.
Yes. Good.
Mm. Poor ovarian reserve raised FSH. Early raised FSH. Ma'am, is it is pointing towards ovarian failure?
Yes, ovarian failure or low ovarian reserve.
Mm.
And apart from this, what about semen?
Male is also a oligo, and the morphology is also
Yes, so male is male oligo, so it will be ICSI for male, and for female it will be
donor oocyte.
donor egg. So look for the option ICSI with donated egg.
F.
E is the answer. E is the answer. Why
Because
donor sperm? Donor sperms are not required. These sperms are doing well.
yeah, we can try.
Yes. Answer is E. Very tricky question. So now age is 46. You have to fasten the treatment. Low ovarian reserve. So you have to take egg from somewhere. Oligospermia. Yes, the couple has got their own sperm. So you ICSI with the donated eggs. So now AMH is very high. Tubes are patent. Azoospermia.
ICSI will be done with the partner sperms.
Azoospermia means there is no sperm at all. Oligospermia you can do ICSI.
Donor
Azoospermia, donor semen.
and this is G, ma'am. G.
But this patient has irregular periods also. So you will do something for that. How is M? Patient is having irregular period, hyperandrogenism, AMH high. So this is a picture of PCOD. So female is having PCOD, male is having azoospermia. So for
Induction.
PCOD, you will do ovulation induction. For azoospermia, you will do IUI. So it will be donor IUI. Okay. So ovulation induction, ovular ovulation induction with donor IUI will be the answer. M. I think this answer should come right.
No treatment is required.
Yes, that is the C. C is the option.
Ma'am, it will be K.
Yes.
This is must be taking anabolic steroid abuse. A.
Yes, because he has got proven fertility.
Yeah.
So and no medical issue. Steroid. Testes become small. Yes, as the hormone are fine, but the testicular biopsy shows germ cells are there. So that means they are not growing further. So maturation arrest.
Okay. Yes. Klinefelters.
So FSH is elevated, testosterone is normal. Though testosterone should not be normal. So these are the features of Klinefelter syndrome. Actually, they have got testicular failure, so testosterone is less. But I don't know why their question is normal. Men is tall. So what are the clues? Agiospermia, tall, FSH elevated, and gynecomastia, small testis. Okay, small testis. So the it is going towards Klinefelter syndrome.
To continue to try for 10 more months.
Yes, so here
14
you
months
can
there, 24
yes.
months is required.
So now here see the progesterone ovulation is there. We have to see three things: ovulation is there, semen is good, tubes are fine, unexplained infertility. Before they have tried for 14 months, so they have to try for 10 more month. After that, they will be eligible for IVF.
To try to continue, try to another ma'am A, B, C, D one, 12 months more.
But she is 38 years of age.
Uh, proceed with this IVF.
So she is 38 years. So
Mm.
according to our guideline, after 36 years of age, we have to like do the special considerations. So she already tried for 2 years. Okay, she already
Mm.
tried, already tried, and there had been no pregnancy. So she's ovulating, tubes are okay, semen is okay, unexplained infertility, 38 years. You can't wait for so long. She has to go for IVF.
Ma'am E.
Yes, because now you can see progesterones are fine, so she's ovulating, patency is there, and tubes are patent, and the semen is normal. So unexplained infertility. Now previously she had tried with another one, but right now she has tried for 18 months. So a person can have 10 relationship. So we will not consider infertility with all those 10. We will take the definition of fertility from right partner, the current partner. So with the current partner, she is with 18 months. Unexplained infertility is a diagnosis. So she has to wait for 6 more months. After that, she'll be eligible for IVF. So answer is try for 6 months. Any answer?
Privately funded IVF, because NHS will not going to fund as she has already got one son.
Okay, so she's ovulating. Lap and dye shows tubes are normal. Semen is normal. Unexplained infertility. But she has already tried. She has already tried for 2 years. So she should unexplained infertility. Tried for 2 years. She should go for IVF. But as she has so it will be self-funded IVF. So these are the criteria for IVF in NHS. So they should not have any child from any relationship. They should have a healthy weight. They should not be smoking, and there will be age criteria. Age criteria we already know from the NICE.
Ma'am, is it C?
Why lap and dye? Any comorbid factor is there? Any topic, PID, infection?
No. Ma'am, it will be D then. Exactly. Lap and dye test will not be there.
Yes, so ovulation, you will do check for progesterone, tubes for HSG, semen analysis, answer is D. Okay, so that's all about it. So thank you, all of you, for joining.
Thank you so much, ma'am. Thank you so much.